My talk, you really understand what I mean. Do we really know the dengue virus in terms of the biology, in terms of the pathogenesis, in terms of the biomorphology? And I pay my special thanks to Dr. Raymond Sinaji for his kindness to invite me to come over. And it took me almost 27-hour flight to here. It's worth, yes. And thank you for this beautiful place. As you can see, the photo was taken in front of the hotel. So I will start with the mosquito-borne human viral disease, as we all know, and in here. And these are the mosquito-borne that have been well known for this virus. And they all introduced mainly by Aedes aegypti. And they all, except the West Nile virus, okay? And chikungunya also Aedes aegypti. But the clinical presentation, they are all different. Some of them encephalitis, some of them arthritis, some of them will have the developmental disorder or the hematological disorder. The key question is, these are all delivered by the same, almost the same mosquito virus. How come the clinical manifestations are so different? Well, this is the key question. So we started to answer that probably the target cell are probably different. So we like to use the in vitro culture. For instance, you use a lab panel, which is a MEG1 cell. It's one of the megakaryocytic cell. It's from the tumor cell. So you put down the dengue virus, chikungunya, and JEV, they all replicate very, very well. However, you put the same kind of virus onto the human bone marrow cell, and you found that chikungunya will not replicate. Okay, so dengue and JEV will replicate well. And if you further define by suspension cell and adherent cell, you will find that dengue only replicate in the suspension cell, and chikungunya will replicate only on the adherent cell. And JEV can replicate in both adherent and suspension cell. So this just tell you, fundamentally, they do have the difference in terms of the target cell. But we all like to use the in vitro cell to study what we see. But come out to the in vivo, there's a difference. Okay, this is one of the key messages that I'm going to deliver. And in terms of the dengue and Zika, they all look like a brother and sister, except Zika, in terms of the fever-wise, a little bit mild, and rash also a little bit mild. And in terms of the target cell, Zika have been known that they probably infect the neuron stem cell, but dengue, in our hand, you will know, we are thinking that they are infected the hematopoietic stem cell. Okay, because the dengue have been demonstrated that they can infect the testicular culture, but in Zika, so far there is no data for that. Mother to trial, both of them capable of doing so, and whether they can induce the Guillain-Barré syndrome, both of them are, and whether virus can be isolated from the semen or not. Zika can be, and dengue has not. So I hope that next time when I come, I will give you the results for this one, whether the dengue virus can be isolated from the semen or not, because we recruit 40 people who are infected by dengue virus, and we're going to follow them every 6 months. Okay, so in terms of the sexual transmission, and Zika have been shown, but dengue has not. Okay, so come back to dengue. Dengue is a global issue, and it has been mainly in the tropical and subtropical. And Taiwan, you see, very, very tiny in here. And because it's a very red dot, because we do have the big outbreak last year. Okay, so the economy burden also very, very severe, because most of the time, one family member gets sick, maybe many members of the family will take care of it. So that's why the economy cost is significantly. And dengue, so far, even though we do have the vaccine that have been completed phase 3 clinical trial, but the outcome, the limited efficacy and potential consequence make everybody worry that whether this vaccine can really protect or not. And so the antiviral, so far, we haven't have anything yet, okay, even though many of them are in pipeline or maybe still under development, and I will show you more results of this and try to answer the question why to develop dengue antiviral drug so difficult. And dengue have the 4 serotype, 1, 2, 3, 4, and they are different from other flavivirus family because they do have the 4 genetic cause related distinct serotype. And today, the mosquito control is the only way it looks like can contain the disease. So in terms of the age, it also different from the region. Okay, like Thailand, mainly on 10 to 12, 24 school-age children. Brazil also similar to trend. And in Taiwan, we always be very old for some unknown reason. Always be 50 and above. We don't know why. Okay, and our children does not get dengue that often, but severe dengue always be in the very old people. And this is by Dr. Sabin. And for those of you who didn't know that, Dr. Sabin have been working on dengue for almost 14 years, trying to develop dengue vaccine in 1941 to 1954. And he failed. So he switched to the poliomyelitis. That's how made him very famous, and people forgot he did work on dengue, but he only published 4 papers. Okay? So one is talking about 600 pages, how he failed in his vaccine development to dengue, published in the World War II, one of the military journal, in talking about the attenuated strain of the dengue virus. But he did contribute a lot to dengue, including the neutralization assay, including the different serotype. That's how different serotype defined by Dr. Sabin. In his human study, by bitten the mosquito, and then there's an incubation period, normally 5 to 7 days. And after that, you will have the symptom fever, and then it lasts for a few days, and the rashes start when the fever, at the end of the, the viremia always go down, and the fever slowly go down. Okay, this is the difference. Okay, so the viremia period, patient only suffer from fever, and the hemorrhage occur very often not during the time the virus get clear. Okay. In terms of the animal model, so far we do have lots of the infection model. But infection, that's what I say, viremia only induce fever. Okay? So what does it mean, that animal model? But disease model, we don't have it, which is the dengue hemorrhage fever and shock. Okay? How does this happen? We don't know. So because of this kind of issue, we still don't understand what is the actual mechanism, even though some people say they understand. Okay? But if you ask them specifically, there's no answer for that. The key question is why only small percentage of people will get the clinical symptom, okay? And so far, like the vaccine, yes, they do have, but it's limited efficacy. And antiviral drug is still far removed to be seen. And one of the key questions is for these people who recover from dengue infected, the long-term follow-up, we don't have any data for that, okay? And majority of the people are asymptomatic. The asymptomatic become very sensitive issue these days because they found that dengue can be transmitted through the blood transfusion, bone marrow transplantation, and organ transplantation. Okay, this suggests that they may have the persistent or latent infection. And this latent and persistent may accounting for the dissemination of the dengue virus or even the reactivation, this kind of thing. So my talk were mainly on the symptomatic, okay, later on. So in terms of the antiviral drug to dengue virus, if you search in the PubMed using the keyword antiviral dengue, there's a typo in here, and you will see almost 1,100 publications. But if you get into the keyword slowly, in vivo, in vitro, in phase 1, phase 2, it comes down to single digit, very few, okay? And very recent, people try to use a nucleoside. If you use a nucleoside word, they do quite a few of that, but nothing so far in clinical trial. And for the repurposing drug, they do have some, but still the clinical trial still far removed because very recent, this paper talk about the failure of the repurposing drug. So far, there are many of the repurposing drug, but I think in my prediction, they will still just waste the time and money. Okay. So what are we chasing for? Okay, since we have so many literature talk about, but how come we cannot get anything into the clinical trial and see the efficacy? Is there a reason for that? In my mind, they do have some key information that have been missing link. And first of all, it's the bench research. In bench research, you can find almost any kind of cell, tissue culture cell, can be infected by dengue virus. Okay, people have done that. There's this table lists about 23 different kinds of cells that can be infected by dengue virus. But in clinical, it's difficult to find this cell being infected in patients. So what we found is the stem cell easily to be infected by dengue virus. And also the megakaryocytic cell. If you differentiate them from the bone marrow, and then they got infected very easily. So this is, we think, the stem and progenitor cell probably is the missing link in here. That's one thing. The another thing is, people think that the liver cell is potentially to be infected by dengue virus. So everybody use the Hu7 to screen their antiviral drug. But in our hand, we never see healthy liver got infected, only the tumor. This is from the surgery. So we took out the tumor part and pale, and you found that the healthy liver cell will never be infected with dengue virus, only the tumor part, okay? So this is one of the potential missing link in here. And another missing link is endothelium cell. So endothelium cell, some people think that the dengue virus infected endothelium cell. Is that true? I don't think so. Because if dengue infected endothelium cell, today it becomes contagious rather than mosquito-borne. During the period of viremia, dengue will not break down the endothelium cell of the blood vessel and migrate to the skin, just like the Ebola. So this is the two different things. So like this, in the Ebola, you can see the virus in here, but in dengue, there's no virus in here. So that's that the endothelium cell is dysfunctional rather than being infected. Okay. So even though some people really go into that, and I think that need to be clarified a little bit. In terms of the virus structure, from the in vitro, you can see whole bunch of beautiful. Everybody looks the same, almost identical. Regardless Zika, regardless other things, very similar. But in our hand, for the dengue virus, you look at like this. It looks like in the morning, our sunny side up egg, that kind of morphology. This is what we found in dengue patient. So this is one of the important missing link in here. So the epitope presentation, the biomorphology, neutralizing, they are all different. So this is we are talking about the translational side versus basic research side. There's a big gap in here. How do we bring them together? We probably have to rethink about it. So this kind of different morphology maybe explain the whole thing. Neutralizing titer in dengue virus, you measure with the virus produced in vitro, never be predict, useful to predict the protection against dengue virus infection. Okay, maybe that is the reason. Maybe that is also the difficulty to develop the vaccine. Okay. In terms of the co-infection, I say, we do have the cohort with my wife working in Thailand, and she is a pediatrician, and taking care of the children born from the mother who are HIV positive. So they have the HIV exposed and HIV infected. This kid has been followed for more than, right now it's 21 years. So all of them survive. Some of the exposed ones become HIV infected. But in this cohort, after many years of the study, none of these subjects developed dengue hemorrhagic fever. Okay, none of them. The reason, we don't know why. Okay, they do have the antibody. They do get infected multiple times, but they do not develop dengue hemorrhagic fever. So my wife always tells me, say that if we would like to develop dengue vaccine, we have to understand this co-infection scenario. Then there is a vaccine, hopeful for that. Okay. So for those of you who doesn't know where Taiwan, this is the Taiwan very small. So in 2015, we do have the big dengue outbreak. So the Tainan is my university right in here, right in the heart of the disease. So we do have the almost 23,000 cases in 2015. Okay. So what is the risk factor? The age. So you see, we have about how many people die? All in all, have 128 in our city die. The average age die in here shows 46. Average is 75 years old. It's very old. Okay, and the non-survival, and then co-infection is one of the key in here as well. For the co-infection, just to repeat the slide. For the co-infection, many is the bacteria. So the bacteria, most of them are the gut bacteria. And if you measure the endotoxin in the bloodstream, you will see that they do have the LPS. So dengue shock may be likely due to the endotoxin rather than what everybody looking for, the cytokine. Okay, this is one possibility. Okay, we don't look into this kind of issue. And this is probably in elder people in Taiwan case, but I'm not sure in children you will do the same thing, okay? Because all the cases that are presented in here are from Taiwan, and all the patients are already old, okay? But during this time, we also see some of the very obscure virus. For instance, there's a patient, number 2, number 4, number 5. In here, we cannot use the RT-PCR to detect anything in the serum or plasma, but we can recover the virus from the PBMC, okay? It's very intriguing, only 3 patients, and very funny. So we are curious to know what are these viruses. So when you look at the EM, looks like they are virus, okay? And well, we don't know what are they, okay? But when we try to see that they may be Zika or Dengue, so we use a primer. As you remember, the current test for the universal primer cannot pick up this one. So we use a homemade one for the Dengue, and Zika using the commercialized primer. So all these 3 patients' genome can be amplified, but with different size. And then we do the amplified sequencing, and very intriguing in the way that they do not homology to anything, but they are virus. They can form the plaque. So we don't know what they are, and I'm welcome to distribute these 3 viruses to the audience if they are interested to take a look at whether they are Dengue-like Zika virus or Zika virus-like Dengue virus. Okay, so this is one of the potential difficulty to diagnosis of the Dengue. Okay, so maybe some of the newborn mosquito-borne virus in here, because Aedes aegypti also deliver many other flavivirus. So we don't know what are these virus is. So in circulation, okay, that is one possibility. In terms of the asymptomatic, so recently people think that asymptomatic infection is the one that probably accounting for the outbreak because they are easy to be picked up by the mosquito. Okay, so in the 2015 outbreak, we try to see whether we can pick up some of the asymptomatic infection or not. So we went out to the market to breed the people. So altogether, we breed about 2,600 people. And after the big outbreak, the general population, only 10% of them develop the IgG. So we still have the long way to go to get the herd immunity for the community for that. And while we are doing that, we pick up one of the asymptomatic people. This is a male, and who is a truck driver, and every day running around. So his viral load in serum and the plasma also very high, but we cannot detect the NS1. Okay, so that there's no IgG and IgM not detectable. And we are curious to know, because they are in his blood, there's a high viral load, so we look for the EM, just like the acute, and also confirmed by the immuno-EM. These are indeed dengue virus for that. Okay. So because of these kind of things, we are concerned about the blood safety in Taiwan. So we went out to do the almost 6,000 sample from the Taiwan Red Cross, and we use a rapid test. It's not sensitive enough. And we did see that by the RT-PCR, 1 positive. And this can also deliver the infectious virus for that. So they trace down the donor, the recipient as well, and who accidentally also have the dengue. So this kind of blood transfusion have been known in Puerto Rico and by American Red Cross. And they can detect, they use a very sensitive, they detect the viral RNA. And this, most of the people also negative. At that time, because Puerto Rico is the endemic, so people think that these people are just beginning of the infection. That's why you don't see the dengue antibody. Is that true or not? But we don't see, we think that some people naturally will not develop antibody against dengue because the virus needs to survive. That is our point. In terms of the persistent infection, these people, some of them are repeated donor, and we found that the viral load maintained the same after 6 months. And you do the viral sequence, they are identical, almost 99% homology to each other from the first donation to the 6 months later. So seems like there is a persistent dengue virus infection in here, okay? So when I go back to Taiwan, we accidentally also found that 2 subjects who are potentially also the persistent infection because we use them, breed them as the healthy control. And somehow, some way, in their PBMC, we can recover the infection virus. And happen to be one subject is dengue 2, one subject dengue 1. And I will come back to the dengue 2 later for that, because that subject we follow for a long time. So in terms of the persistent dengue virus infection, it has been known since 1939 that it's potentially in nature, happen in nature, okay? And also the latent, viral latency has been proposed by Dr. Hada in 1971. Dr. Hada is the person co-discovery of the dengue virus, co-isolation of the dengue virus with Dr. Sabin in 1941, okay? So persistent infection, is it possible? Because in tissue culture, many tissue culture show that it's possible, okay? And this is the monkey testicular tissue culture. In here, if you infect them, and the virus can shed for up to 3 months in this study. So suggests that the stem cell may be involved. So in our lab, we try to establish whether persistent infection is okay or not. So we use a humanized mice, and we do in different ways that we use a fresh bone marrow to do the transplantation. So everything is coordinated and difficult, but it's manageable. And we use a low viral infection, 1 × 10⁴ IV infection. And then after the humanized established, and then we infect them, and during the acute breeding, and every 2 weeks we breed them. So here we go. The first result we see is persistent, can up to, this has been 170 something days, no update for that. So you can see that the virus can persist for 100 something days, and the cell looks like it's an early megakaryocyte cell that carries the virus. And another pattern we see is latent. The virus disappear and come back, disappear and come back. And this mice is very healthy. Now it's 370 some days. And there's 3 mice in here. And they're very, very long. So it looks like there is a latent viral infection in here. Hiding and come back, hiding and come back. And we found that the cell that accounting for this kind of phenomena is early megakaryocyte progenitor cell in here. Okay? So we try to establish this persistent infection in the ex vivo. So we get a donor and infect them and to see what happens. So I can see that after the acute, very often the virus will get clear, and on day 30, and you will see that they come back. Okay, so we don't know how does this come back. So one of my PhD students working on this, and according to her, she is able to identify the cell phenotype during the acute and the latent phase are different. Okay, so I hadn't got the result yet for that. So this is the number dengue 2, this healthy subject we follow for a long, long time. So there's during this right now it's 900 days, and we can see the P, the virus can be discovered in his blood about 4 major times. Okay, the virus can hide and come back, and hide and come back. And I did not present in here is that last year, 2015, we do have big outbreak of a male who happened to be infected by dengue virus as well, and recovered, and he died this year in July because of the car accident. So the family decided to donate the organ to benefit of the other people. So what the organs that have been donated to the recipients are cornea, liver, heart, and kidney. And so they benefit many people, but 2 people develop dengue. Anyone can guess which organ? It's a kidney. 2 recipients get 2 different kidney, develop dengue virus, okay? And one of them almost died, get a severe, but survived, okay? So the doctor who asking me said that he saw that only the HIV will have this kind of phenomena. How can it happen in dengue? And I said that, well, because we don't know much about dengue in terms of the latency and persistence. Okay, so, and the virus recovered from these 2 people are identical, but unfortunately, they cannot trace back to the donor because of the donor, they only did very limited amount of the biopsy. So the first thing I asked them, do they keep the bone marrow? This is where we think the virus high. But they said that they would never think about that, to keep the bone marrow. Okay, so right now in Taiwan, we are setting up the screening process for the organ donation to screen for the dengue virus. That is one of the incidents come out from this very recent fiasco for this. Okay, so the dengue virus does have a chance, looks like they do. And the second people that we identify, number 5, dengue 1, right now we have about 2P. It's only about 600 days, something like that. And have the 2P come up, and I did not show in here. Okay. So in terms of the long-term fish, because from the previous slide that we see in here, so what we found is that these people, they have the very abnormal stem cell population, such as the CD133, CD34. So we always curious to know, because it's exceptionally high. So we think that maybe somehow related to the hematological disorder. So that's why it made us to go back to do the data mining in Taiwan health insurance, because we have the nationwide health insurance program. So you can take the data out from the big band. So what we found is that for the people who recover from dengue virus, within 3 to 10 years, develop the cancer and leukemia and other things. So we found that leukemia is very significant, but in particular, myeloid leukemia, somehow associated with the dengue virus from the patient who recover eventually after 3 years, and then they have this kind of association. Okay, so we don't know whether this is true or not, but we still try to figure it out for that. Okay, so in terms of the last 2 slides, one is for the dengue virus, probably they do have the multiple life cycle. We know a lot in tissue culture, but we don't know much about in human, because we don't have a very good animal model for that. In terms of biomorphology, they're also different. One thing I did not mention is that the cell membrane or the surface of this viral particle, which is derived from the megakaryocyte. So if you do the staining, it's a CD612 positive for that. Okay, so this new finding probably can save some of the thinking, in particular for the drug development. Because I think we waste lots of money in tissue culture in the wrong cell. Probably that's how everything you get it good, then come to the animal, monkey, everything fail. Okay, I think if you're going to think about to develop this kind of drug, and I prefer the antiviral drug, personally, I do not think vaccine is going to be useful and also difficult to develop. Okay, so the antiviral drug probably have to use the right platform to do the screening for that. So it always comes to the point, how are you going to look at your crystal ball? Okay, so you look at different angle, you may look at different way. You may have a different outcome. So it all depends on how you take it. So you would like to look at the same angle as me, that's fine. Look at your own angle, that's fine. It all depends on which direction you're going to go in. Okay. So at the end, and I have to thank you for all the people that involved, and also the NIH grant. We still have the NIH grant with the Emory Vaccine Center on the dengue, and also the Taiwan, the National Science Council, and the people who are working in the lab. And I did not present a lot in here is that the primate study, but some of the information that we use, and we can make this kind of conclusion from the primate center, by the Emory Primate Center and the Tulane Primate Center to combine together. So I'm able to address this kind of issue. And I hope that this kind of thing can let you know that we really don't know much about the dengue. And we know a lot in tissue culture, but in terms of human being, probably we don't know much about it. So that will conclude my talk. Hopefully you learn something from it. Thank you very much.